Welcome to the NWA-ETC Project ECHO. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
We'd like to welcome Dr. Joanne Steckler back to ECHO. Thank you for being back with us. Dr. Steckler is an associate professor here in the Division of Infectious Disease and a local expert on PrEP, and I will just turn it over to Joanne to give us an update on PrEP.
Great, thanks. Before I say anything else, I have no personal or financial conflicts of interest, and the only other disclosure that I often need to make is that sometimes we talk about medications that are not being used according to FDA. One for sort of Truvada is approved for daily use of PrEP, and no other medications are currently approved. I'm going to assume that many of you have already heard about it, know about the studies. My understanding was that there's already been an ECHO talking about the basics, so I'm not going to talk about the randomized trials that led to the FDA approval, but we can, if people have questions at the end, we can talk about a little bit. Really, I was asked to talk about our experiences here in Seattle and start answering some of the questions that we have post these randomized trials. So what we're going to talk about is our demonstration project here in Seattle, and I have to apologize again that we are Seattle and Washington focused, and some of the things that I'm going to talk about in terms of resources may not be available to you if you are outside of Washington State, and part of our goal is to figure out how to get those resources to you. But we're going to talk about patient selection. We're going to talk about the big bugaboo for PrEP, which is adherence. I'm going to talk a little bit about side effects and monitoring for side effects. We can talk a little bit about behavioral disinhibition, the sort of transition of people from using condoms to not using condoms because they're on PrEP. And then I think one of the biggest concerns from providers is how it's going to get covered. And then I'll give you some resources that are both Washington State focused and then national resources that you can start with if you are interested in prescribing. The randomized trials led to sort of the recognition that PrEP was effective. There were still several implementation questions. And these are, how do we get PrEP to the folks who are highest risk, where we're going to get the most bang for our buck in terms of cost and cost effectiveness? Will those people be willing to take PrEP? Will they be adherent to PrEP? And then the questions of how do we monitor it in terms of real-world HIV testing, recognition of acute HIV infection, because as you know about PrEP, the concern about drug resistance is greatest in people who started PrEP during the period where they were antibody negative. We'll prep this question about sexual disinhibition and insurance coverage. So just the first question of who's most at risk for HIV and how do we target PrEP to them? Your local epidemiology is going to be different than what's here in Washington and what's shown on this slide. This slide that I'm showing you is results from iPrEx in terms of two of important concepts. One on the left is the number needed to treat, that's on the y-axis. That means how many people do you need to give PrEP to in order to prevent one case of HIV. People with the highest risk, you're going to need to treat fewer people in order to prevent more infections. Along the x-axis is the epidemiological term population attributable fraction, meaning how many people who acquired HIV in this study reported that risk factor. And what you're going to see first on this first slide in terms of the behaviors that had the lowest number needed to treat were in the iPrEx study, which was the randomized study of men who have sex with men and transgender women. The greatest risk in that population for people to acquire HIV were people who reported cocaine use, were people who reported, interestingly, anal intercourse without a condom with an HIV negative partner, obviously a partner they thought was HIV negative, then receptive anal intercourse without a condom with a known positive partner, and then people who had syphilis during the study. But the thing about this is that the population attributable fraction is further to the left. So though you may not need to treat as many people in order to prevent a single infection, if you focus only on these patients, you might not reach everyone who might acquire HIV in your population. And the reason why I have that little tug of war, this was my addition to this slide from Susan Buckbinder, was that I think that in many ways we have this sort of internal struggle as providers with sort of from a public health perspective, we want to get PrEP to the people who are most likely to seroconvert. But on the other hand, that you may see patients who have lower risk factors who are interested in PrEP who are sort of really going to represent the vast majority of people who are going to get HIV infected. And so there is a struggle with trying to find the right population. And that's sort of the next comment on the next slide is that if you look at the risk factor with the greatest population attributable fraction, meaning of the people who acquired HIV, the most of the people reported having receptive anal without a condom with any partner, whether that partner was known to be positive, said they were negative, or they didn't know the serostatus. So if you were going to try and prevent every HIV infection you could, you would focus on basically anyone who had, and these are men who have sex with men, reporting receptive anal. So again, it's sort of a balance of how do you approach selecting the right patient. I want to tell you a little bit about what we're doing in my project in Seattle. I was interested, after PrEP got FDA approved, of building a clinic. This was, we were starting to think about this in 2012 and 2013 before the Affordable Care Act rolled around. So there were a lot of changes that were about to happen, but know that the context for this was before that. So we were interested in a clinic, figuring out if we built a clinic where anyone, regardless of insurance status, could come, who would show up at our door. And we were interested in looking at whether or not adherence differed depending on whether people had insurance or not. I'm not going to talk much about what we do for adherence. We're using a non-FDA approved device called Wise Pill that's not yet available in this country. But I'll show you some of our adherence data. We had to go through IRB approvals, and so we enrolled our first person in October 2013, and we've been focusing on high-risk men who have sex with men, and those are men reporting an STD in the last year, sex with someone who is positive or unknown serostatus, more than 10 partners in the last year, or methamphetamine or proper use. Our pilot project was funded to enroll 50 people and follow them for only 6 months, and that's sort of where we sit right now. We were funded again by the University of Washington for a program called by the Royalty Research Fund, and we're partnered with Gay City, which is a local community organization, with 2 pharmacies here in Seattle, Seattle Meds and the HF Pharmacy, and Washington State Department of Health is providing a little bit of support also. In general, this pilot project was intended to be real-world-ish. So it's still a research project, but we didn't provide study meds to people. We provided a prescription for them to take to one of our partner pharmacies, ideally. So we were really trying to pattern this based on the CDC recommendations for sort of who was eligible, who should be excluded, and the frequency of follow-up. So we were looking for high-risk negatives again, and excluded anyone who had symptoms of acute HIV, the fever, rash, sore throat, muscle aches type syndrome. And we did defer enrollment in at least 2 people who reported those symptoms to us. We wanted to make sure they were truly HIV negative when we started PrEP. We excluded at least 1 person who had a creatinine clearance below 60. We screened for hepatitis B, but haven't excluded anybody. We haven't seen any women, so would have excluded for pregnancy, but PrEP for pregnancy is a whole other topic we could talk about. And then finally, we started the project excluding anyone who had recently gotten PEP or PrEP from another source. And this is a bit of controversy around the country in terms of whether or not you should, following a PEP, an exposure that required PEP, whether you should delay or not. There are some people who think that if someone had PEP and could have acquired HIV, that you really should make sure that they're HIV negative before starting them on a true drug therapy. There are others who think that if someone has frequent exposures requiring PrEP, that basically you should just continue to go straight to a step down after they complete their 28 days of PEP. There's no right or wrong answer, and again, if people have questions or want to talk about it, we can. Our visits are consistent with the national guidelines. We do, with perhaps a little bit of extra follow-up, we do a screening visit where it takes me about 45 minutes or so to talk about PrEP with someone, whether or not PrEP is right for them, and a little bit about the study. We talk a lot about adherence. As you know, adherence is very important. And we talk a little bit about the importance of condom use. But I, as a PrEP provider, partner with Gay City, and those Gay City testers and counselors are doing a lot of the behavioral counseling because many of my study subjects have reported in other interviews that they don't like talking with me about their condom use because they want to sort of feel like PrEP is being sex positive, and that the condom use discussion, they are providing much more accurate and truthful information to other people and not to me. We have them also do a survey on a computer, which I know many of you won't have access to. Every visit, they get an HIV test, they get a check of their kidney function, and they get STD testing, including blood for syphilis, as well as any site-appropriate chlamydia and gonorrhea screening on the time that they're starting, and then every 3 months, which is, again, consistent with guidelines. We're doing Truvada prescribed for daily use, and I basically tell people that they should be taking it every day. It's not as important as if someone were HIV positive to take it at the same time every day, but taking it at the same time really helps with people remembering to take it. I tell people not to beat themselves up if they forget a dose every once in a while. And I have a protocol that says if someone is falling below 4 doses or so a week, that we really address whether Truvada is right for them. And that's based on modeling data that you may have heard about from iPrEx that suggests that 4 dose really conveys over 90% efficacy. We do text reminders with people on a weekly basis, which is probably more than is necessary. All of our participants are very adherent. And then we use, again, this Wise Pill device, which I'm not going to talk about more. This next slide shows our 47 of the 50 people that we have enrolled out of the 71 people who we officially screened, with a lot more people that we've talked to but who decided not to officially screen because either they decided that PrEP wasn't right for them because they were low risk, or they wanted to get PrEP from somewhere else aside from my study, or they were moving out of state, or there are sort of some other reasons, or sort of cost has been a barrier for a few people, although again I'll tell you about a program that makes it less of an issue. Again, sort of typical population for Seattle, we're entirely either male, and we've had 3 transgender people as part of this project. We're sort of moderately risky, as you can see, with some folks falling below really sort of any income and are on Medicaid, Medicare. Medicaid in Seattle in Washington has covered PrEP without a problem. In terms of adherence, we again get both the self-reported data and the Wise Pill data, and our population, again, research population, both reports that they are taking almost all of their doses, and this is confirmed by Wise Pill, which basically shows us every time the device was opened like a MEMS cap. So really good adherence in this population, and there's suggestion from the open label extensions that we may be seeing better adherence in the open label than in the randomized trials because people know it works and the people who end up on it are really sort of believers in it. I think our payer data, and the next slide is really interesting because the most important thing I think is on the far right, which is our patients have had very little out-of-pocket costs for their PrEP. The vast majority of private insurance here in Washington, again, I apologize for that I don't know sort of the coverage across outside of Washington State, but private insurance will all cover it. There was one problem that we had with one of the private insurances that was through the exchange, but after they started doing a few denials, we actually had our Washington State Department of Health folks twist arms a little bit, and now that insurance company is back to accepting. Again, Washington State Medicaid is covering it. Gilead has a program to pay copays, and then we have this great program here in Washington State for anyone who is eligible based on a few risk criteria. They are truly negative, that it's based on HIV DAP, so drug assistance program, that they will cover all of the remaining copays for the people who have 40% copays with the exchange insurance. And they have even started paying for some people's insurance premiums, sort of like the HIV drug assistance program. They are sort of playing around with other things. They currently only pay for medications and don't pay for laboratory copays, but that is also something that they've been discussing. And I know in group health here in Seattle that laboratory copays end up being a significant problem. And so even though we have these programs, that there are still some financial reasons why people may not want to go on PrEP. This is just the website for what PrEP DAP is, includes a bunch of other links. I think in the resources, the website for this. The other thing that if you are in Washington, that this website lists providers who are interested in providing PrEP. So one of the things that we have here in Washington is trying to match patients who are interested with providers who are willing to prescribe. So Washington State has this on the PrEP-DAP website. It links to Seattle-King County, which I presume none of the folks on here are in Seattle-King County, but Seattle-King County maintains their separate page. And I looked at some of the other Northwest states, couldn't find anything, and then asked on this national chat room and couldn't find anything. So one of the things that you'll hopefully see is request nationally, if you are interested in prescribing PrEP, is getting on a list so that patients can find you if you're interested in that. But we sort of in Washington are probably more advanced than most of the rest of the country in terms of getting PrEP out there and getting providers trained. So hopefully those of you who are on this are interested, and we can use you as champions because we're doing a lot of trainings. This is just, the state gave me some information about who they have on this PrEP website, and the thing I just want to point out is that they're mostly covering prescription costs with that. Many of you, I'm sure, are starting to see more and more requests, and this is true because of a variety of different things. One is that nationally we're seeing more knowledge among the target populations, and so people are starting to get asked a lot more, learn about more, and getting more prescriptions. And that's been borne out by our local knowledge, by the PrEP sort of prescriptions, and Gilead occasionally will report on the Truvada prescriptions around the country, and they are saying upticks. Still, it's underprescribed compared to those who might need it. I want to give you a few tools, and this is from one of my colleagues at Group Health who has been doing this in terms of billing. I don't do any billing, but there are a few codes that you can use for billing for CPT codes in both the ICD-9 and 10, and I can send you, in addition to that, I have a document with EPIC templates for those of you who are on a computer system and want some documents of how to write notes, as well as lab smart sets for EPIC. Unfortunately, we can't seem to share EPIC templates and smart sets across EPIC institutions. And then finally, currently there is a hotline that is funded by the CDC that is based at UCSF for providers who have questions. And then just the link to the guidelines that were recently published about more the information that you might need to know in terms of how to prescribe, what labs to check, with what frequency, in the guidelines that were just published over the summer. And I have the link there at the top. And I think that's all I have. So PrEP and PEP just being part of sort of a package of HIV prevention. It's not intended to replace anything else, but just for some people that this is an appropriate thing to be talking about.